Yeah, hi everyone, and welcome to this other edition of the Cameroon Town Hall. It's immense pleasure to have you all again today, and on this to discuss this really very important subject. The Cameroon Town Hall, as you all know, was birthed early in the days of the COVID-19 pandemic, and the goal really was to bring together professionals from different spheres of life to share knowledge on their different areas of expertise. And so far, this platform has grown an enormous network with representatives in multiple countries, and different people from different healthcare domains have had the opportunity to knowledge share, exchange ideas, and network and that. So it's really been an immense pleasure to be part of this consortium, and I really wanted to take the time to welcome each and every one of you for joining us today. Today we will have a really very interesting discussion and really interesting subject, something that's really key and pertinent to not only us in Cameroon, but it's very pertinent for the entire African continent, and also really an important global health subject. So we are really thrilled to have Mr. Kwan Jacob with us today. So thanks a lot for accepting the invitation. That said, I just want to take the time to welcome our chair, Dr. Mono, to formally introduce himself and to maybe give us a word of welcome.
Brian, thank you very much. It's always a pleasure. And I'm particularly very excited today. Each time we're going to talk about hand hygiene and the job that ECO project is doing, the WASH project in Cameroon, the state of WASH. So it's very important. I think we tend to neglect the basic things in life and make a difference. I always say throughout human evolution and since the time we started discovering things, from WHO did an analysis back in the year 2000 to see what projects and what decisions that they made have changed mortality. And the number one decision that did change mortality worldwide was hygiene and sanitation. The improvement of hygiene and sanitation ranked number one. Discovery of antibiotics and ranked number two, vaccination ranked number three. So you could imagine the impact of hygiene and sanitation to our lives. So that is very important in everything we do. So I think it's an important topic today for us to discuss and get to know the subject better.
Yeah, thanks. And it's really great, and really thrilled that we have Jacob to talk to us about this subject. He's really been an expert and a really strong advocate for hand hygiene. Not only in Cameroon, he's also been a part of the Society for Healthcare Acquired Infection Share organization as well. So I think, and I initially heard about Jacob for the first time when the Africa CDC set up the Infection Prevention and Control Program, which essentially brought together multiple healthcare providers across the continent, and he's been a part of that group as well, and a really strong voice in that consortium as well. So I'm really thrilled that we have someone in that forum who is equally as passionate about this particular domain. So really looking forward to an exciting conversation and an exciting exchange. So that said, I would like to turn it over to the chair, who will give us some updates in what's happening in the world in the space of COVID-19 and monkeypox and probably other infectious disease threats that have been emerging. Over to you.
Yeah, Brian, thank you. While we buy time for others to join us, I know a lot of people are interested in this particular subject for today. So as I said, it's an enormous pleasure for us to have Mr. Kwan Jacob with us today. And I think he's going to do a great job. So starting with, we are seeing a situation where the world is being submerged in multiple infectious disease problems happening at the same time. COVID-19 is not over. We have polio in certain areas. We're having Ebola. We do have monkeypox. So there is several things happening, and getting ourselves around this is difficult. This has put most Centers for Disease Control, they are really overworking, and they are trying as much as possible to get each and every one of these pandemics under control, but it's becoming difficult. Now, is the pandemic over for COVID? I don't think so, but it's very difficult for us to make conclusions. This just depicts what the situation in the world really looks like. This is the number of deaths that we've had out of COVID-19 worldwide, depending on each region. I think Africa has been the most, the area least hit by this situation, but now we do have the situation of Ebola occurring in some countries in Africa, like Uganda, that you guys all have heard about in the news. So you can see here that the mortality due to COVID has led to decrease in life expectancy for humans. We've been having this increase over the years, and we have now this situation where life expectancy has decreased. So this actually shows we're getting better at managing COVID patients. We're getting better at dealing with the pandemic. So the death rate is actually reducing. Lethality out of COVID is really decreasing. And vaccination still works. I'm still advocating for those who are in Africa. When vaccines are available, we should get ourselves vaccinated. I know there can be several controversies around this, if this is even an African problem, because there are other things stepping up, like Ebola is coming up. We also have monkeypox, and we have cases. This was the first reported recent case of monkeypox in Cameroon. This was in the Bongé and Kumba area. And those who are in Cameroon who don't know, there have been cases that have been reported recently. I just decided to make sure we know that this is not a problem only of the West at the moment. And the CDC and the NIH, there have been people, scientists who are trying to modify the monkeypox, but are we making trouble? That's a question really that came out in one of the big journals. Now, for monkeypox, a lot of us know it's an orthopox. We do know that the first cases was in 1958, and we know a lot more about this right now. There are actually two clades, which we do know. Now we're dealing mostly with the West African type, and the modes of transmissions now are very common. And I think each and every one of us should look out for this, especially those who are nurses, those who are lab technicians, those who are physicians, public health specialists around. We should know that these cases can also occur in Africa and in Cameroon. And we do know that it's endemic in certain areas in Africa, really. So the number of cases worldwide is really reducing, which is a good thing. Number of new cases, and mortality also has not increased over this period of time. Here is just recently showing you that there have been 75,000 cases that have been reported up to October 22nd. Now you can see in the US where the highest number of cases are, you can see the areas where we do have cases. This is regional. I usually show this because this is the characteristic lesions that we used to have. But this time around, these are the lesions that we have them. It looks more like sexually transmitted diseases. There's more in the genitals of most people. So you get to see those who practice different forms of sexual intercourse, anal lesions, vaginal lesions, oropharyngeal lesions. So here you can see this, so don't miss them out, even don't miss the classical form. So we do have vaccines that are still under certain, we have them here, but they are not FDA approved fully. So we have them used under certain programs. So we should know that this exists, and those who are at risk should be able to get them. There is also some treatment which is available for severe cases. So Piviramab is available. There are other treatments that are available. Now, getting to COVID, it's important for us to know that the COVID pandemic is not over. There is slowing down in the number of deaths, but because of the number of people who are vaccinating, but we're having more mutations. Right now in the US, we have the Omicron BA.5, which is still worldwide the most majority. There's BA.46, which is the number is rising here. I'm going to show you, this is data as of yesterday, showing you the different prevalence of the strains we have circulating in the US, and it reflects that in the world. The BA.5 is the most frequent, BA.4.8, then you have the BF7 and the BQ1. So here you can see about a week ago, this is what we have, and the numbers are growing for these other subvariants. Here is just for people like Brian, those who want to know detailedly where the origin for this is coming from. You can actually look at the slides. I'll share them. I don't want to bore you guys with all these details, but it's important to know that there are certain variants like the QBB and the BQ 1.1, the XBB and the BQ 1.1, where they have certain immune escape, and we are looking into that, and most monoclonal antibodies do not work on them. So this just shows you genetically how the variants vary from each other and the different skip mutations that are present. Here is a salad soup. You may want to take this and look at different subvariants that are circulating. For those who are interested, I'll share the slides. Here is just showing you exactly what we're dealing with in terms of the new variants that we have and their level of lethality and infectiousness. So these subvariants and variants are competing among each other in order to survive. And we still do know that it's important for us to get reasonable protection methods. So we have been very slow in acquiring nasal vaccines and researching in them. These are the several ones that are being either in clinical trials or approved. Here you also have, this was a study that really showed that those who had an infection had nasal protection better than those who had vaccination. So it shows that that could be a means of really protecting people. So here are the pros and cons of getting a booster, a second booster. And I advocate for those who live in areas where there is still COVID to be able to get themselves boosted. It's important to also know that these boosters do help and protect us from getting infected. Here is the most recent paper showing what placebo versus getting a second booster does to you and reduces the amount of infection. Or chronic, or what we'll call the long COVID is still a problem for areas where there were a lot of COVID patients. So you can see that there is something I wanted to talk about. A lot of people do talk about obesity being responsible for the number of deaths we had in the US, but it's not really the main explanation, right? Over time, we've seen that those who are not vaccinated have actually increased the number of people who die from COVID. So looking at the data from Japan and comparing that with US, you can see a lot of things. Obesity alone did not really explain the death. There are so many other factors that you can look at. And I'm going to show you from country to country, just letting go mask. Japan is still using masks and other barrier methods. Their death rate is pretty low compared to others. In Africa, we have a young population that can explain several things. There is a lot of sunlight. There is no winter, so the virus doesn't stay alive. There are a lot of factors. But here you can see Japan has more elderly people than US, but actually more people, more than 3 or 4 times died from COVID in the US compared to Japan. So these methods are still very important for us to look at and try to analyze things like this. So this is just showing you the number of people who have gotten. The first one is those who were vaccinated initially. Japan was always higher than the US. Those who got a booster, Japan is higher than the US. Look at those who got a second booster. You can imagine there's a big gap in knowledge. There's a big gap in acquiring vaccination. There's a big gap in death also. So these are data that I always want to see. The Swiss cheese model is still the model that you need to use for every infectious disease, be it Ebola, be it COVID, be it patients who have polio. We still need to think about this and think about all the different methods that could work. Here, this is the data for Paxlovid, and I'm including that as part of it. And I think Africa needs to have this tool in order to, in case we do tend to have more cases, then we can be able to fight and add this to our toolbox. So here is just some other data just showing you over time mortality of and hospitalization of patients in COVID in the US. It has actually drastically reduced since we had a vaccine. And here is mortality based on those who are vaccinated versus those who are not. So here you can see the amount of excess death. COVID really killed a lot of people that we cannot explain. There are a lot of data that is missing out of COVID. So here, the development of COVID has led to improvement in infectious disease overall. There are several research going on in Ebola in order to make RNA vaccines, also taking place in other diseases such as HIV. So we should not, COVID has come also with its own blessings. And you can see here for Zika virus, influenza virus, there are several people trying to use this technology in order to make life better for us humans going forward. So are we out of the pandemic? I hope we should be out of the pandemic, but we are not. And we're presently in an endemic, or it's going to stay with us for a while, like the flu. Now, are we done with variants? We're having very sub-variants, and maybe Brian is going to tell you, no, we're not. There are animal reservoirs, a lot of them existing, and you do have, we're no longer putting on masks. The lack of global commitment has been an issue. Even surveillance of refuge tanks is not possible in many places in Africa because of the way we do with our refuge. So we are unable to actually know if we're not testing the variants that are circulating around. Wearing masks in planes have been stopped in most places. So you see here, there's still potentials for pandemics to occur. So here you can see that vaccines actually do save lives. That's just the data I'm showing you guys. These are the different variants that are existing. You can see within 6 months, a change in the different variants that existed just in the world. 6 months, they all switched, and now we have problems with monoclonal antibodies. So here is just showing you the variant tree. And are we really done? Can we lock ourselves out of COVID? I don't think so. So we need to still keep running. The virus is wiser, it's running faster than us. We need to look at different methods and try to be ahead of this vaccine. There's been the end of the road for masks. I think it came very fast. And I think we need to advocate for this in crowded places and other areas where there is still infectious diseases. I tell you, there is data in my hospital where I work. For a whole 2-year period during COVID, there was no one case of influenza. And because everyone was wearing a mask, so actually, it actually reduced infections in other diseases. This is the state of the disease worldwide right now. The number of cases we have as of today, the number of patients who have received vaccines and treatments. So you can see that the number is gradually reducing every day. The rate of increase in the numbers is reducing. Cameroon, for the past 1 month, they have not updated anything. So it means there have been no patient. I don't think so, but there's just been lack of update. And here is the data from the US. This is just showing you how far we have gone in terms of developing a vaccine. And I hope this technology can be enhanced and used in Ebola, also used in hepatitis C, and used in Zika, used in chickenpox, monkeypox, and many other things that we do have, and HIV in particular. So these are the number of shots worldwide, and we can see that access is still a problem in Africa for vaccines. Even when we have the vaccines, we don't have people to get them. So this is the water reed trial, which they're trying to get a pan vaccine. We're still looking up at that. And here you can see data that shows you that vaccines do work, which is very important. And when are we going to have a new variant? We don't know yet. And it's something we need to still just talk about. And I hope next time we have a new one, we're not going to lock ourselves up. And Africa is going to be ready with a cold chain, because we're still not here. It looks like we're not actually learning from our mistakes. So we could have vaccines, but we're unable to actually use them. So it's really been a ride with COVID, and I think it has helped us. It's important that we know from here. I'm just going to use the slides to tell you there are several treatments for COVID. And for now, the ones that are affordable in Africa, we do have dexamethasone steroids. We have tocilizumab is not really very affordable and not present. Remdesivir is not. Molnupiravir is not. Paxlovid is not. So you see, there is really a problem in us as Africans getting all this treatment. Baricitinib is actually available. So this is data showing exactly where it should be used. I'll share this data. This is data showing you the indications for treatment for those who are interested in treating patients once they have them. So we can actually use this data, and I'll share the slides with you guys. You guys can look at the slides and know exactly when to treat patients and the mechanism of actions on each and every one of this, and the data and the clinical trials that Evershield, now there is resistance to the variant circulating, so it doesn't really work quite well. So you can see that with time, you need to be up to date in order for you to actually fight this. And I would hand over the floor to Brian to tell us a little bit more about other things that are happening, maybe 5 minutes before we move over to discuss with Jacob our next topic. So Brian, over to you.
Yeah, thanks, Dr. Mona, and thanks a lot for preparing this updates and summaries. It was really exciting, interesting to hear this, and thanks a lot. Very disturbing to hear about the ongoing outbreak of Ebola in Uganda, and puzzles me because wondering if we learned anything from pandemic preparedness and outbreak response through the COVID-19 pandemic. So I'm wondering, Dr. Mona, what you think about, what are we missing in terms of outbreak response efforts in Africa, and what kinds of areas do you think, what should the priorities be in terms of how do we prevent this? Today, I think the World Health Organization has reported about 64 new cases of Ebola in Uganda, and there are almost 39 deaths, I think, or maybe 40%. The case fatality rate is almost 40% among those who have been infected. So clearly a lot of people are dying. It's definitely concerning. It's definitely a public health emergency. So how do we best prepare? I mean, initially we had, just a few weeks ago, we had just one case. We had just a little cluster of cases, and that has kind of expanded and grown over time. So definitely a deficit in pandemic preparedness and outbreak response efforts. And I'm just wondering what you think on the horizon, and how can we better prepare to avoid these kinds of things happening?
Yeah, Brian, I'm not an expert in pandemic preparedness, but I would want to say that this has shown us exactly that we have not learned from history. We have not learned from our recent history about COVID. We have not learned from what even happened in Ebola in Liberia and Guinea. So I think it's time for us to build healthcare systems that are not one program concentrated, where we can harness the same healthcare structures or infrastructures to take care of multiple diseases. And I think the infrastructure that has been put in place for COVID, in many countries, they have been sponsored because it hit the West very well. So there was a lot of money that was pumped in many of these countries. Like Cameroon has multiple areas where they can do PCRs, even right up to the primary centers in different regions. So like multiple countries should be able to test for Ebola, get the different primers, and be able to actually test quickly, get diagnosis quickly, and treat quickly and isolate patients quickly. So you don't need different PCR kinds of platforms. You need the same platform, but you need to be able to have same technicians who are trained in order to help take care of these situations. And the governments too need to put their money where their mouth is, and be able to understand that we need surveillance. We need active surveillance in the zoonotic medicine, those who do animal surveillance. We need to do that too in Africa. We need to know where this Ebola is coming from. How did it get to us, and modes, and when next are we going to see the next pandemic? But I think what you're proposing is a good topic for us to get an expert who will talk about this. It's an amazing thing. I'm going to see if we can look for an expert where next time we'll talk about it. And I think you'll be of great help too, because I think that's where you're also doing a lot of work in that field. So Brian, over to you.
Thanks. And I just had one last question. You mentioned that the case reporting from Cameroon is not so good. I think clearly at this point in the pandemic, case numbers mean different things now than it meant early in the pandemic. So probably I'm wondering, what metric would you use to determine severity rates, for instance, in a place like Cameroon? What would be that indicator that, hey, the Ministry of Health should pay more attention to this? What would that metric be? Because case numbers with the level of community and herd immunity we have now, is probably means something completely different than it was, several months ago, or maybe earlier in the pandemic.
Yeah, so I'll just try to be brief. I think the best way to get to know what is circulating in the community is the number of cases in the hospital. But we do have to acknowledge that majority of our people don't go to the hospital when they're sick. They still go to native doctors, they still run around other places and seek for help, and they go only when they're dying. So the number of deaths also attributed to COVID, if they're being tested when they get to the hospital, may help us know exactly the circulation in the community, because we're not actively testing. Nowhere in the world is actively testing anymore. So I think it's important that we do that.
Yeah, thanks again, Dr. Mono, and it's always a pleasure to hear this update from you, and thanks a lot for bringing this bringing us all of this information every other week. It's really exciting to hear about the state of infectious disease and emerging infectious disease across the continent, and what's happening in Cameroon, and how we can leverage on what we've learned globally and regionally in the pandemic response efforts, and how we can really translate those lessons and those findings into policies that really impact the lives of vulnerable people. So thanks a lot, Dr. Mono, for that. And I just wanted to turn over to Mr. Jacob. I just wanted to say how truly and deeply honored we are to have Jacob with us today to share about the importance of hand hygiene and the state of WASH in Cameroon. Jacob is, like I mentioned earlier, I got to know about Jacob through a consortium that was initially put out by the Africa CDC on hand hygiene that brings together lots and lots of infection prevention and control nurses from across the continent, and he's been a strong voice in that consortium as well. So Jacob is he's an infection prevention and control nurse. He's based with the Cameroon Baptist Convention Health Services. He's been an epic hero for infection prevention and control since 2018, and also been part of the Infection Control African Network, which advocates for hygiene and prevention of healthcare acquired infections across the continent. So he's been in this field for a very, very long time. He's been practicing, he's been part of the IPC committee for, I think, since 2011 or even earlier, if I'm not mistaken. So he has really been in this field for long. He's the one who introduced what we call today the alcohol-based hand rub production, which has revolutionized hand hygiene practices and contributed to the successful eradication of neonatal sepsis in the maternity units in the health facilities of the Cameroon Baptist Health Convention. And we all know how much neonatal sepsis contribute to neonatal mortality in our setting, in our context. So I'm really looking forward to hearing more about him. He's also an advocate, or he's also part of multiple professional international societies in this same area of infection control and prevention. He's a board member of the International Federation of Infection Control. He's a board member of Infection Control African Network. He's a member of the Association of Professionals in Infection Control and Epidemiology, APIC. He's also been a hero for the Society for Healthcare Epidemiology of America and the Infection Prevention and Control Association of Cameroon. So, and also a co-investigator in the development and piloting of family care for IPC orientation projects. So it's really a great honor, and I'm deeply humbled to introduce Jacob to this discussion. Really, thank you so much for accepting the invitation to share about your experiences in the field, what you've all the things that you've learned, and we absolutely look forward to hearing from you and engaging with you in the question and answer session. Thanks a lot, Jacob. Over to you.
Yeah, thank you, Brian. I was wondering if you are really talking about me. Thank you for the excellent and wonderful introduction. I want to thank all of you for the opportunity that you've given me to share my knowledge about IPC WASH in Cameroon. A lot of you have inspired me since I discovered the town hall. And I always look forward to the town hall Saturdays with a lot of anxiety. Please, if you can see my screen, you kindly indicate so that I can move ahead.
Yes, we can.
Oh, great. Thank you. We will be talking today on the state of WASH in Cameroon, but I would like us to begin with football. You know, we are all football fans, and I know a lot of you are looking forward to Qatar with a lot of expectation. And this is one of the faces that we will be seeing in Qatar. He has made history as a player, but now he's going to Qatar as a FECAFOOT president, which means he has changed his career. And I don't know whether he's going to make it as he made it in the past as a player. And we are all aware that in the 1990s, these are the people that inspire us. And this is the team that we are looking forward to meeting in Qatar. And the question I'm asking, and I'm sure all of you are asking, whether they are still going to make us proud as we did in 1990. Of course, football is not only for males, it is for females. And all of these people are looking up to these people, to Etofis, who is the FECAFOOT president. So now the question I'm actually sharing this not to talk about football, but to ask, you know, we all know the ambience that goes around football. And I'm asking, how can we use football in order to promote IPC WASH in Cameroon? I mean, what can these guys actually do? They have the dollars, but I believe that if they are aware of some of the needs in Cameroon, I am sure that one or more of them would like to donate at least a borehole or more to a community or to a health facility in Cameroon in order to serve the population, just like Sadio Mane is doing in Senegal. So on to our discussion, we will be talking about the state of water, sanitation, and hygiene, that is WASH in Cameroon. And this is the outline we are going to use. We will begin with the introduction. We will go to the importance and benefits of WASH. We will look at the global WASH resolution and the targets. And then we will see what progress has been made and what gaps still exist. We will also look at the WASH standards, and then we will come now to the state of WASH in Cameroon, which will be highlighting some findings of a survey that was conducted in 2020. And then we will talk about the consequences of poor WASH, and then we will end with conclusion and recommendation, and then questions and discussions. Generally speaking, WASH stands for water, sanitation, and hygiene. And WASH generally is essential for almost all healthcare activities. And it is always important for the protection of the staff as well as the patients and visitors within the health facility. In fact, if you can imagine a health facility that does not have water, then staff will not be able to wash their hands. They will not be able to wash the surroundings, to wash the equipment. I mean, it will be a disaster. I mean, you cannot imagine that kind of a setting to be called a health facility in the first place. So it is the cornerstone of infection prevention and control. So if you do not have WASH, then you really cannot talk about infection prevention and control. So in current language, we actually say WASH is the hardware, and then infection prevention is the software. If you take it to a computer language, you will know that the hardware cannot run without the application, and therefore you need WASH in order to implement infection prevention and control in the healthcare facility. And then the absence or poor WASH actually can lead to healthcare associated infections. And once they occur, some of them are going to develop resistance. We are going to prescribe antibiotics, and the more antibiotics we prescribe, then the higher the risk of resistance. And then the problem keep complicating, and then healthcare now becomes very, very expensive and almost above the reach of an average person. Now, WASH actually is very important because we require it in order to protect the staff. We need it to reduce healthcare-associated infection as well as mortality. And in economic terms, once you have WASH, it is actually a cost-saving measure because you are going to reduce the infection. Patient will recover quickly, and then they will go home happily. And once they go home happy, then they are likely going to come back again to that same facility, and then more patients are going to come, and the facility is going to make more money. So as I said earlier, WASH has multiple benefits. It is required for safety. It is required for disease prevention and control. It also boosts the staff morale. Imagine when the staff are able to have water and other WASH facilities, and they do whatever they are going to do, they feel more motivated, to perform their duties effectively. And then when you have wash, it also shows that you are also thinking about the people. Now imagine a facility where there are no toilets. It means women and girls especially would not be able to use that kind of a facility. So wash has multiple benefits. I am not going to be listing all of them. Now, in the year 2019, the World Health Assembly in resolution 2072.7, sorry, actually prescribed 11 activities that the member states were supposed to carry out, and I've highlighted 5 here. The first thing was that all member states were called upon to conduct a comprehensive wash assessment. And then the second thing, after doing the wash assessment, they will identify gaps, and then they will develop and implement the roadmap in order to close the gaps. And then the third activity was for countries to establish and implement the minimum wash standards. Then the fourth one was to develop policies and standards, as well as indicators for monitoring wash. And then the last, which I am going to highlight here, was to integrate wash indicators into the national health activities, which means it's supposed to be part and parcel of health management information system. So these are the 5 out of the 11 activities that the World Health Assembly prescribed to be implemented between 2020 and 2030. Now, according to this, the resolution, by 2020, all countries of the world were expected to have conducted a baseline wash assessment. And then by 2022, it was expected that 60% of the country would have met minimum wash standard. And then by 2025, the number will move up to 80%. And then by 2030, then 100%, that is all countries of the world, would have attained minimum wash standard. Now the question is, from 2020 up to now, how far are we? Now, some little progress has been made. A lot of countries, especially countries from the East African zone, they have developed guidelines, they have integrated wash into the national health system, they have developed standards, they have developed policies, but it appears Central and West Africa is actually not doing enough. Well, they might be doing something, but it appears it is not reported. But as far as I know, I am not sure that they are actually meeting the targets as expected by the resolution 72.7 that I mentioned above. Now, despite the little progress that has been made, significant gaps still exist. According to the recent WASH report that was published 2020, we still notice that nearly half of the world's population live without a safe toilet. And this number of people actually are practicing open defecation. And if they do open defecation, they contaminate water systems, they contaminate food, and every other thing around. And therefore, this can actually lead to significant diarrhea, especially within the age ranges of 0 to 5 years. Now, about 2 billion people still use drinking water from contaminated sources. And only about 50% of the health facilities have hand washing facilities at the point of care, which means by the bedside wherever services are discharged. A lot of facilities do not have hand washing facilities. And we know these are the areas where infections occur. And if there are no hand washing facilities within at the point of care, it means that infection will still continue to spread. And lack of adequate sanitation facilities for girls reaching puberty actually makes them more likely to miss schools, and maybe they will perform poorly in school. So poor wash affects the whole society, beginning from the health facility to the community, to school, girls, women, and so on and so forth. Now, We have minimum wash standards that were established. And according to these standards for water, every health facility must make sure that water is available from an improved source within the health facility. Now, in most of the facilities, water is available, but outside of the facility, which means the staff will have to go and carry water before they will come and use it in the health facility. And once you don't have water within the facility, it makes it very difficult in order to, to perform cleaning activities. And the water must be of good quality and quantity, and it should be piped right to the point of care. And the facility also has to have a storage system that is able to reserve water, that in case of any damage of the system, they can be able to use water for up to 48 hours without interruption. Now, concerning sanitation, the standard required that improved sanitation facilities should be available, and they should be separated according to staff and patient, which means staff toilet, patient toilet, and then according to gender, which means male toilet, female toilet. Now, meaning that every unit is supposed to have a minimum of 4 toilets, 2 for patients, 2 for staff, and among the 2 for patients, 1 should be for females, 1 should be for males, and same for staff. And then the toilets are also supposed to be labeled and clearly identified. And then in that facility, they must have at least 1 toilet that is adapted for people with limited mobility. For example, somebody on a wheelchair should be able to access the toilet, which means the door should be wide enough to admit a wheelchair, and then there should be support around somebody so that somebody who is wheelchair can be able to support his or herself from the wheelchair to the toilet and from the toilet back to the wheelchair. And then the toilet also must have facilities for women to manage menstrual hygiene. Of course, all health facilities, they have both male and females, and the females who are on their menses are supposed to change their pads and so on and so forth. And then when they change their pads, they should be able to have a place so that they can safely dispose of whatever they have changed. And then they should also have hand washing facilities so that they can be able to perform hand hygiene after using the toilet. Then for hygiene, the health facility is supposed to have functional hand hygiene facilities at the point of care or alcohol-based hand rub. And it should be available by every bedside, usually at the arm reach. And it could be delivered using different systems. Either it is attached to the wall by the bed, or to the bed, head of bed or foot of bed, or whichever way the facility wants to go about it. Then for waste, the health facility is supposed to safely segregate waste according to the different types. And then each facility, each unit must have a minimum of 3 bins, 1 for general waste, 1 for medical waste, and 1 for shops. And then for environmental cleaning, the facility should be able to have protocols. And then the staff that are responsible for waste management should have received training so that they actually know what to do and they can be able to protect themselves and avoid taking unnecessary risks. And even though recently this standard have been updated and a few other domains added, for example, climate change has been added, and then social and gender inclusion has also been added. So these are the ones that we had before. And therefore, every facility is supposed to measure their level of coverage, wash coverage against this standard. Okay, now this standard actually also has some tools that we can use to assess a facility in terms of how much wash they actually have. And therefore, in 2020, we actually used that tool to evaluate 103 health facilities in 6 regions, in 6 of the 10 regions in Cameroon. a majority of them from the Northwest, 11 from Western region, some from the Southwest, some from the Center region, and then 2 from the Littoral region. And when we analyze the data, we discovered that according to this graph, the brown bars, they represent hospitals. The gray ones, they represent integrated health centers. Then the green ones, they represent health posts. Within the Cameroon health system, health posts are actually not officially recognized health facilities. But however, because they are found almost in remote areas, in some of the communities, they actually use them very heavily, I mean, as if they are actually hospital. And therefore, we actually decided to take them into consideration. Now, if you look at the bars, you will discover that in terms of wash coverage across all the domains, in terms of cleaning, in terms of hand hygiene, in terms of healthcare waste, sanitation, water and the management, as well as hand hygiene framework, you discover that the hospital, the coverage is better in the hospital, then it is lower in the integrated health centers and much lower in the health posts. Now, if you look at water, for example, in the health post, for example, only about 3 out of 10 facilities have water. Meanwhile, in the health centers, about 5 out of 10 facilities have water within the facility. And then in the hospital, it's about 7. Now, if you look across, you will see the trend is actually the same. So wash coverage is actually better in the hospital, then lower in the integrated health centers, and then very, very low in health posts. Now, even though we are talking about figures, but you know, if you can imagine only one facility, if we were only 1 out of 100 facilities that does not have water, then you can imagine the number of people that will be infected within that healthcare facility. Therefore, there is actually no reason for any health facility not to have basic wash coverage. They must have basic wash coverage in order to provide quality health care. But this is not the case in many health facilities in Cameroon, as well as other developing countries. Now, we are going to look at this data in a little more detail. Now, in terms of water supply, as I said, water must be available from an improved source, which means it could either be a tap or a protected well or a spring that is not exposed to contamination. Now, according to our findings, 61% of the health facilities that we assessed had water within the facility, meaning that only 6 out of 10 facilities have water within the facility. And then meaning that some of the facilities did not have water at all. And then some, they were carrying water from a neighboring area before they are able to use. And so this is actually a very, very huge gap. If you translate this into the number of people that are using health facilities without water, that cannot be able to use a toilet or clean equipment or do all kinds of things that we would do within the health facility, you will discover that it will turn out to be a very, very big figure. Now, in terms of hand hygiene, according to our findings, only 56% of the health facilities that we assess had functional hand hygiene stations at all points of care, meaning that about 4 out of 10 facilities do not have hand hygiene stations at the point of care. Now, in terms of sanitation, sanitation deals with toilets, for example. Now, in terms of sanitation, only 35% of the health facilities that we assess had basic sanitation services, which means they had a good toilet that is well labeled and designated according to gender and staff. And then we discovered that 71.8%, which is almost 72% of the health facility did not have toilets that were adapted for people with disability. Meaning that if you have any person with disability visit such a health facility, they are not going to use, or they will struggle before they are able to use the toilets that are available. So it means we are not yet disability friendly within our health facility. And if we translate this into percentages, about 15% of the population of every country is living with a disability. And if we have a toilet that can exclude up to 15% of the population, then that is really very, very significant. And then at the same time, just about half of the toilets of the facility had toilets that were adapted for menstrual hygiene management, meaning that if females are using these facilities, they are not going to attend to their menstrual needs, and that would not be a very good thing. Now, these are some of the toilets that we found in some of the facilities, especially the hair post. Now, if you look at the one to my right, you will see it's a very fragile toilet, and it's not even protected, it's not covered, meaning that somebody cannot use it when it is raining. And then if you look at it, you see a patient or a child can easily collapse into the toilet. Of course, these are found in very remote areas, but as long as it is in a health facility, we think that there is actually a problem. Now, in terms of waste management, there were actually a lot of gaps in terms of waste management. Only about 35.4% of the facilities had basic waste services, meaning that in places, in big facilities that needed an incinerator that can be able to burn infectious waste, they did not have it. And then segregation of waste was actually very poor. And then in most of the facilities, the staff that managed waste were not trained at all. And then in 81% of the facilities, there were no protocol for waste management. There were not SOPs, meaning that, in fact, if you assess one staff to another, they will do differently. Once you don't have protocol, you don't have SOPs, then it means that the practice is actually not going to be of standard. People, individuals, might choose to do whatever they want, saying they don't have any reference document. Now, in terms of environmental cleaning, we discovered that only 43 out of 103 facilities met minimum standard, and 14 facilities did not have sufficient cleaning material. 22 facilities did not have personal protective equipment. We mean that the staff that are doing cleaning or waste management, they will not have anything to protect themselves. And majority of them, they were using disposable gloves. And in some facilities, even disposable gloves were not even available. And then 35 facilities had no insecticide treated nets over the beds. And we know Cameroon is a malaria endemic area, and people can actually contract malaria within the health facility. Then in most of those facilities, bed spacing was even less than 1 meter, meaning if the patient has an infectious disease, that patient can easily contaminate the next patient on the next bed. And then 71 facilities had no record or checklist to evaluate their cleaning. Which means the staff that are responsible for cleaning had nowhere to indicate whether an area has been cleaned or not. And this is really a problem when it has to do an audit. You will not really be able to ascertain whether the area has been cleaned or has not been cleaned. Then in terms of management, this one is actually evaluating how the housekeeping, especially the housekeepers, are actually managed within the facilities. And we found out that up to 81%, up to 81 facilities out of the 103 had no annual budget. This is a very, very serious matter. If facility do not have budget for IPC, it means it is actually impossible for them to implement it. And this is one of the very, very important areas that we usually use to measure or to assess how willing or how ready a system or a facility is to implement a WASH. So any facility that does not have a designated budget is actually classified as a facility that is not willing or ready to implement a WASH. And then 40 facilities had no trained housekeeper, and majority of them were depending on volunteers. They had housekeepers that are not actually staff of that facility. We mean that on a certain day, they might choose not to come. Nobody will have any, it will not be any problem to them. And if you have a health facility that people who are managing waste are not contracted in any form, then it means there is actually a very, very big problem. And then 44 facilities had no job description for housekeepers, and many of them do not perform annual staff appraisals in order to identify those that are performing well and they reward them. So in terms of management, this is actually a very, very big problem. So it means that the health facilities generally have actually been abandoned to themselves, and the staff actually somehow are not committed in any way to the facility at all. And then majority of them, if you look at even how much they are actually paid, you will discover that it is even not significant enough in order to even encourage them to do a good job. So we think that in terms of management, there is still a lot that we have to do in Cameroon. Now, the question we are asking is, despite all effort, WASH is not a new concept. It featured in the primary healthcare concept in 1978. In all the global health agenda, WASH has always featured, even right up to Millennium Development Goals and now Sustainable Development Goals. Despite all of this discussion, why has WASH coverage remained persistently low from 1978 and up to date? And what are the consequences? So these are some of the things we will be seeing in the preceding slide. Now, the causes of poor WASH, according to me, is limited funding. Even though it is difficult to measure how much each facility actually is able to assign or designate for WASH activities within a health facility, but we can be able to estimate using the Abuja Declaration, which mandated that every country should be able to designate 15% of their budget for health activities. Now, most of the countries are below 5%. Only a few countries are above 5%. And for Cameroon, I'm sure the budget that is allocated to the Ministry of Health is between 4.5 to 5% of the total budget, which is usually not sufficient enough to be able to meet the health needs of the country. Now, the second problem is inadequate distribution of resources. Now, even the few resources that we have, how do we use them? How are they distributed? According to Professor Monique So of late, he said the way they use budget in Cameroon, they use what he actually described as the reverse bell, meaning that the greater chunk of the money is concentrated at the areas where less activities are carried out. For example, if you look at the health system of Cameroon, from the central level to the district level, the district level is the operational level of the health system. But if you look at in terms of budget, you will see it's the reverse. More money goes to the supervisory level, which is at the central level, and then less money to the operational level, where the activities are carried out. And this will affect the implementation of activities at the level of the district. And then we also discover that even the distribution of the resources between rural and urban is also a problem. According to the study that was conducted by the Ministry of Public Health in 2010, it was discovered that 43% of the health resources, including finances and human resources, are concentrated in two towns, Douala and Yaoundé, that are serving only 18% of the total population, which means 43% of the resources are dedicated to 18% of the population, and that's a very big problem. And then the last thing, which I think is also a contributing factor, is the lack of political will. Of course, I'm not going to elaborate this. Of course, we know where the politicians, they did not really see it as a need. Then they are not going to put policies and allocate money for the activities of, for this kind of an activity. Okay, Now, what are the consequences? The consequences of poor wash are actually huge and span across time. Now, in terms of sustainable development goals, if you don't have wash, then 6 out of the 17 sustainable development goals are not going to be attained. And this is actually very, very significant. And it's not only that, a lot of women are going to be left behind, women and girls, because they will be disproportionately affected. This is because in terms of water, for example, these are the people that go fetch water. And if there is no water, it means they will cover long distances. They will not have time to be able to carry out the household chores. Girls will not be able to attend schools and so on and so forth. So if we don't have adequate wash services, then it's already widening the gap between males and females. And that is really a very, very big problem. And it's estimated that up to 15% of the females are going to be affected if we do not have adequate wash within our communities. Then it will increase the burden of healthcare associated infections, and it will also drive off antimicrobial resistance because we are going to prescribe more antibiotics, and the more antibiotics we prescribe, then the higher the risk of infections. Then we are also going to have multiple outbreaks. Of course, in our earlier discussion, we are actually wondering whether we have actually learned lessons with the previous outbreak that we've often had. I know there are also other things that we need to do, but one of the fundamental things that we need to do is to institutionalize infection prevention, so that we need infection prevention to prevent outbreaks, and we should not wait until when an outbreak occurs, then we are rushing to use infection prevention to control it. So if we strengthen the health facilities and make sure that every health facility and health system has a very strong IPC wash system, then that would be the best way to prevent infection from occurring or to prevent them from spreading when they do occur. So if we do not have wash services, then we will actually be dealing with multiple outbreaks and they will spread and we will not be able to control them. Now, we will also discover that 81% of the world's population, only 81% of the world population will have access to drinking water by 2030, meaning that 1.6 billion of the people will be left behind. 67% will have sanitation services, meaning we'll be leaving behind 2.8 billion people. And 78% of the people will have hand washing facilities, meaning 1.9 billion people will be left behind by the year 2030. So it means sustainable development goals will actually not be attained, I mean, in a nutshell. And therefore, the best way to attain sustainable development goals is to pay attention to wash. So to conclude, we actually have been saying that wash has not been given a proper attention in Cameroon according to the findings we have seen. And we've seen that wash coverage is actually unacceptably low in many health facilities. You know, we have health facilities that patients are not able to use the toilet. They are not able to even drink. They are not able to take a bath. And if you can imagine such a facility, then you can imagine what kind of things will happen. And then the situation is actually worse in health posts compared to integrated health centers and compared to hospitals. And we think that if we assess more facilities, we'll be able to have a better picture of the situation. And we think that there is actually a very serious need for us to promote wash in Cameroon. And the question is, how? I am sure that in the course of the discussion, we'll be able to come out with some at least suggestion that we can be able to promote wash at personal, at collective, and at the global level. Thank you. These are some of the questions that I suggested for discussion, and I'm sure that the moderator will be able to coordinate the discussion session. Thank you for listening.
Yeah, thanks a lot, Jacob. That was a brilliant and excellent and really intriguing presentation, and thanks a lot for sharing those thoughts. I just wanted to give you a couple of minutes for you to maybe grab grab a glass of water just before we launch into the question and answering session. I just want to indicate that if anyone has comments or questions, you can raise your hand, or you could also put those questions in the chat, and we will try to address them as we go on. But in the meantime, I just wanted to take a minute to maybe gauge the audience and what people think just grossly about the state of WASH, water, sanitation, and hygiene in Cameroon, and what people's take on the subject was. So it's really intriguing to me. Personally, I think that the COVID-19 pandemic even further demonstrated the need for the urgent need for us to have access to safe water, and just the need for urgent for access to safe water in Cameroon, because COVID also initially, you could also just by hand hygiene as well, you could prevent that formal transmission of COVID as well. So I think that the need for that, and we've certainly seen a decrease in the incidence of some of those diarrheal diseases in certain settings. The use of IPC like masking reduced the incidence of flu, for example, in the United States. So I think that there's definitely some connection there. So I just wanted to ask a few people in the hall just to hear their thoughts. I don't know, je vois que Guy Moutembi, je vois que tu es dans la maison. Je ne sais pas si Guy Moutembi, I think he's from Gabon. I would love to hear his thoughts about the presentation, and also what the state of WASH is in your country. Guy?
Hello, everybody. Hello.
Yeah, hello.
Yeah,
Hello.
we can hear you. We can hear you.
Good afternoon. Bonsoir tout le monde.
Oui, bonsoir.
Yeah, I'm okay. Je suis à Yaoundé, ça fait trois semaines. Bonsoir. Bon, je suis à Yaoundé depuis 3 semaines, Brian. Je suis à Yaoundé depuis 3 semaines et j'ai commencé la formation que je disais en field.
Okay, it semble qu'on a un problème de connexion, but I think he was trying to say he just he's currently in Yaoundé for the last 3 weeks, and he just started the FETP training program. I think it's a field epidemiology training program in Yaoundé, which is this group that's geared towards building capacity in applied epidemiology in the Central African region. So I'm sure we're having a disconnect, a problem with connection, but
Hello.
Can you hear us? Guy, we can hear you. You can go ahead.
Hello.
Yes.
Hello.
OK, je pense que nous avons un problème de connexion. Et bon, nous allons un peu passer, mais je pense que la connexion n'est pas stable. Bon, nous allons un peu...
Hello. Hello.
Oui, oui. Guy, est-ce que tu m'entends?
Oui, Dr. Brian, je vous entends. La connexion n'est pas bonne, mais j'ai changé. Je suis venu là, il y a un peu plus de signal. Vous m'entendez là?
Oui, oui, on t'entend.
OK, donc je disais bonsoir tout le monde. Je suis à Yaoundé depuis 3 semaines et je vais rester jusqu'en décembre. Je suis venu pour une formation sur l'épidémiologie de terrain avec le projet camerounais de la formation en épidémiologie de terrain, le 3e niveau, donc le high level. Et c'est un projet financé par USAID et chapeauté par CDC Africa. Et donc, le Cameroun est en train de mener le lead de ça depuis bientôt une dizaine d'années. Yeah. Et bon, ça va. Et donc, par rapport à la question posée tout à l'heure, par rapport au thème même et la question posée tellement, je disais, c'est la même réalité. Le Cameroun, le Gabon, c'est la même réalité. Et vraiment, l'approche WASH ou l'approche One Health, c'est vraiment très, très pauvre encore au niveau du Gabon. Et le cas ponctuel, c'est par exemple l'hôpital où moi je travaillais, même avant de venir ici, où je travaillais, c'est un hôpital où vous n'avez même pas de source d'eau. On a eu seulement des sources d'eau il y a 2 ans, mais sous fond de l'UNICEF. L'UNICEF qui avait fait un don, c'est comme ça qu'on a pu avoir une source d'eau à l'hôpital. Et c'est un hôpital de référence, c'est l'hôpital d'infectiologie qu'on appelle l'hôpital de Kembo. Donc, c'est l'hôpital spécialisé dans tout ce qui est maladies infectieuses. Vous imaginez, là-dedans, vous avez par exemple le programme tuberculose qui loge à l'intérieur. Vous avez le programme PALU qui loge à l'intérieur. Vous avez le programme de maladies rares qui loge à l'intérieur. Le programme de maladies parasitaires qui loge à l'intérieur. Le programme de maladies, le programme tabac qui loge à l'intérieur. Et en plus de cela, vous avez même l'hôpital lui-même qui a sa structure. Donc, il n'y a pas de point d'eau, il n'y a rien de ça. Et c'est vraiment compliqué. C'est vraiment compliqué. Je crois que, comme disait tout à l'heure l'exposant, il faut qu'on aille vers cette approche du informer les gens, que les gens se rendent compte de combien c'est important, mais en commençant même par nous-mêmes, les personnels de santé, parce que nous sommes en fait de compte les premiers exposés à tout ce qui est pathologie nosocomiale, ou alors nous sommes même les premiers porteurs de ces pathologies à travers les microbes que nous faisons passer dans nos blouses, dans nos pratiques, parce qu'on prend avec des patients, on prend avec quelqu'un d'autre, on ramène ça même de chez nous à la maison, on laisse à l'hôpital, et l'hôpital, c'est vraiment l'endroit, mais alors là où on peut engranger toutes sortes de microbes que je ne peux pas imaginer. Au niveau du Gabon, je crois qu'il faudra faire beaucoup de sensibilisation là-dessus, au niveau des hôpitaux, au niveau des pratiques, les bonnes pratiques, il faudra beaucoup sensibiliser là-dessus. Et je sais que le projet ECO n'est pas assez développé encore au niveau du Gabon. Je sais qu'il y a 1-2 personnes qui sont à l'intérieur, mais ce n'est pas encore assez développé. Donc, ce serait la bienvenue d'échanger et de bénéficier de l'expérience du Cameroun à ce sens-là. Merci.
Merci beaucoup, Guy, et merci beaucoup pour cette contribution-là. Just a quick summary in English. So Guy he said he's currently, like I mentioned, he's currently doing the Cameroon field epidemiology training program, which is an organization, which is a program that was set up by Africa CDC to build capacity in applied epidemiology for the Central African region. So I think he's part of that consortium and is currently in Yaoundé to do that program. I think it's going to conclude sometime in December, if I'm not mistaken. And he was giving us a state of WASH project in Gabon, because he's based in Gabon, and he mentioned that the ECHO project in Gabon is not well developed, that there's not a lot of differences between what he has soon presented today and also what's happening in Gabon. They have the same kind of challenges, and they are even way behind in terms of the ECHO project. So it's really great to hear that perspective from a neighboring African country in our region. And so I'm really excited so we can engage this conversation and really think about how the state of WASH can be improved in our region in Cameroon, and how this can be improved in Africa as well. I'm wondering if, I don't know if Dr. Joshua Tambe, I would really love to hear your thoughts as well on what your perspectives have been on this topic. I don't know how you've been thinking about this, how this presentation took you, and what your perspectives are on the state of WASH in general in Cameroon. Dr. Tambe.
Can you hear me, Brian?
Yes, we can hear you.
Thank you very much. I'm still trying to put some few things together because I just had a power outage. So I'll get back to you in the course of the presentation. I'm trying to organize my thoughts. I'm just connecting back. There was no power and then everything went blank. So I'm just trying to put my thoughts together. I'll get back to you. Thank you.
Oh, awesome. It's great, and I also just wanted to take the opportunity to acknowledge the presence of the regional of the regional delegate of the Southwest, regional delegate for public health for the Southwest region of Cameroon, Dr. Echo Filbert. And it's really a great honor to have you in our midst today. And also thank you so much for all the work and advocacy that you've been leading for the Southwest region, particularly in the response towards the outbreak response towards cholera, which is very intricately linked to this topic of urgently responding to the need for safe water in the region as well. So thanks a lot for your advocacy and fighting fighting in that domain as well. I was also just curious to hear your thoughts on what the state of WASH has been in the Southwest region, so far, and how you perceive the presentation from Mr. Jacob today. Dr. Echo.
Brian, it seems he might not be getting us, but he posted some question on the chat box. Maybe you can look at the chat box.
It's okay. I'm on. Thank you very much. I don't know whether you get me now.
Yes, we can get you very well.
Okay, thank you very much. I am excited and really anxious because it's very interesting. Unfortunately, I connected a little late, just at the end of the presentation. So just got the conclusion and did not really follow the presentation. However, it's a very interesting topic. WASH is very particular, especially in our developing countries, where resources are very scarce. Practically all the epidemics that we have locally are directly or indirectly linked to WASH activities. So I just want to appreciate his presentation on the topic. But since I didn't follow, I posted some one or two, I don't know, remarks or questions to try to get clarifications from the presenter. The first was, I don't understand what he presented as health post, because the organigram of the Ministry of Public Health or the health system is from category 1 to category 6 hospitals, and the category 6 is integrated health centers. And those are the different level of infrastructure or health facilities that are considered in the budget of the Ministry of Public Health. So I don't know, and if the health posts that he considered are not part of the organigram of the Ministry of Public Health, then they will bias the result. It becomes difficult for us to look at them as part of the instrument of government. Secondly, I don't know, I just said, it is very practical that the health facility in a community will not really be different from the facilities of that community. It will not be different from all the commodities, from all what that facility has as utilities. So if you go to a village where people live in mat houses, people live in areas, they use bed stream to get water, it will be very difficult to get a health facility. I mean, because certainly you have an integrated health center there, not a hospital. It will be very, very difficult and practically, I would say, impossible to get a health facility that will have health water or say WASH facilities within that health facility. It will just be a copy and paste from what the community is providing. That's why I would have really liked to, maybe he presented before, but I would really like to see the repartition, what was the sample size and what was the proportion between the category 1 or the different categories of health facilities and what was the proportion of especially water availability. I know that hygiene and sanitation is very scarce in majority of health facilities. Very, very scarce. But water, I really want to know the proportion with respect to the different categories of health facilities. However, I think we, especially in the Southwest where I work, we are trying to improve on that because we've seen that with all the epidemics that we're having, we can't run away from it if we don't improve on our wash facilities. And that is why my wash team at the delegation is practically in the field to try to capacitate all health facilities, health districts first, and health facilities in specific health districts to try to improve on their wash facilities, and also making partnership with NGOs and also different donors to try to provide us with certain facilities that can help us accommodate all what is wash. So, but I think it's very interesting. During the discussion, we'll see how things can be better as a presentation like this has come up. Thank you very much.
Thanks a lot, Mr. Delegate, and thanks a lot for those remarks and those comments. Those were very, very insightful. Wondering if Jacob is on to respond to. I know when you shared the slide with the statistics, with the data, the graph, we only had hospital, and there was no really specification what category in the whole pyramid it is on. And we also had one for IHC, I believe, Integrated Health Services. Then we had the health post. So it wasn't really clear. I think that's a very pertinent question to know what really the distribution or the status of WASH is based on those different categorization of the health system in Cameroon. Jacob, are you on?
Yeah, thank you, Brian. Can you hear me?
Yes, we can hear you.
Okay, thank you. I want to thank the delegate, Dr. Eko. It's my privilege to see him for the first time. I have not seen him since he was appointed delegate. Actually, this study was a small study, small survey. It wasn't funded. It was just done on private personal funds. We actually we just had a small donation. And because of the passion we had, we decided to do a survey, and we really could not cover the whole national territory. We actually did not do a systematic sampling because we would not be able to afford the finances to do a wider study. And that is why I actually mentioned that a bigger study is necessary in order to actually see a broader picture of the situation in Cameroon. However, apart from data, I'm actually living in Cameroon. Most of the facilities, I know what exists there, and I can tell the story even without data, but data is necessary, at least for other people who are not based here to be able to say what the situation is. The situation in some of the facilities is even worse than I've pointed. You know, if we were to look at other parameters of WASH, let me take, for example, water. There is also an indicator to find out the quantity of water that, the storage tank that the facility has is also an indicator to find out whether the water is treated or not treated, and so on and so forth. So if we were actually going to, in this study, we actually just look at whether the water is available or not. We didn't go beyond this. If we were to look at other indicators, the situation would have even been worse than it is. So in terms of the national cover, I would say that it was just a small study covering Northwest, a few facilities. Majority of the facilities were from the Northwest, then 11 from the Western region, I think about 8 or 9 from the Southwest, and then 4 from the littoral, and 4 from the center, and 2 from the littoral. And we limited the number based on the funds that were available. I'm sure that if we had more funds, we could be able to cover the entire national territory and also do some kind of sampling that will cover the different types of facilities. In terms of the health posts, actually, I am aware that the health posts are not official health facility within the national health structure. I mean, I actually indicated that during my presentation, but actually for me, I'm looking at it was population oriented. It's not policy oriented, meaning that even if it is not an approved facility and people are using that facility, it means they can equally get infected if wash is not available. Whoever is managing it actually was not the matter per se. So whoever manages a facility, whether it is government, whether it is private, whether it is community, the wash needs do not change. They remain the same. And if the government or the individuals actually know the importance of wash, they should be able to make sure that whatever they call a health facility, whether official or not official, then it should be able to have basic wash. And let us also understand that in most communities where this health post exists, even though not approved, the community depend on it entirely. I mean, if you have a community where it takes 4 hours to reach the nearest health center, you will discover that that community regard that health facility, even though called a health post, as their own hospital. And therefore, I mean, it will attend to most of their health problems. Whether they will do it correctly or not correctly is not the matter. And so, I mean, in terms of WASH, actually, I decided to be people-oriented and not policy-oriented. And that is why I decided to include all our health facilities that I could access given the means that I had. So I think even though this data is not nationally representative, but I can guarantee that if we do a national coverage, I am sure that we will not have something that will be much different from this the finding that are presented. But however, I mean, this snapshot can actually give us an idea about what the situation is, and then we could be looking for means to be able to do a wider study that can be able to capture the global picture. Thank you.
Yeah, thanks, Jacob, and thanks for those comments and those remarks. And I definitely understand the limitations you had in having a larger sample size. Another thing that you might also consider, I think representative sampling is really important in any kind of epidemiological work, and having as much representativeness is even important. I think it'll be also great to look into those different hospitals that you had and actually break those ones further down to see by their different health categories and to see what the representative WASH coverage was for those individual hospitals. It would be great to see those, to see how that's been distributed as well over time. So thanks a lot for those comments, and I definitely agree with you on the importance of getting more resources to do these kinds of studies in the future. It's really critically important. I wanted to just quickly call on Dr. Joshua Tambe. Just wanted to invite him quickly to make a few comments before I pass it on to Dr. Foma and maybe and the delegate as well. Dr. Joshua. Dr. Tambe, can you hear us? Okay.
Brian, are you there?
Yes, I can hear you.
Thank you very much. I'm actually grappling with a difficult network situation where I am. I want to say that it's been a very interesting presentation from Mr. Jacob. And it's a very serious problem in public health, especially because hand washing promotion, for example, it's a known fact. A lot of randomized control trials and meta-analysis have shown that just hand washing promotion alone can help a lot to prevent infections, especially within the hospital setting. But what I want to say is that part of my reading, and we also had a PhD thesis on that, is that the emphasis seems to be on the actors or the institutions and organizations whose primary activity is to promote health. If you look at our water situation in Cameroon, the situation of public taps, public water supply, normally it should be a concerted effort between other actors. For example, there is the Ministry of Water and Energy, there is the Ministry of Housing and Urban Development and Town Planning, and the Ministry of Public Health. Normally, this should come together and work together in the supply of safe and potable water. It's very, very important. If we lay the emphasis just on the healthcare providers in, helping them to wash their hands, let patients wash their hands, and we don't get much into the other actors who are supposed to make sure that we have good water supply, the pipes are good, the conditions are good, then we keep on having some of the outbreaks, because believe me, even if you do wash properly and the water supply isn't the best, the water sources are contaminated, we keep on having the same problem. But I think the concept is a good one. And that is the major difference with most developed settings, where the concept of wash is not a mantra the way it is in developing countries. I don't think where Muno is seated, wash is much of an issue in his facility. The water is there. They now insist on the hand washing promotion, both for the patients and for the staff. Yeah. In our setting, we are still struggling with having the safe, good quality water, and now getting into the education of the population. So I think all the other actors who are stakeholders in this particular issue of wash are supposed to come together so that it is a success. And then just one, I was just thinking aloud when the delegate was talking about health facilities in Cameroon, classifying them from 1 to 6 is actually very, very correct. Because the last category, which is supposed to be category 7, according to the organizational chart of the Ministry of Public Health as published in 2013, category 7 is supposed to be what they call ambulatory health posts, which virtually doesn't exist. So for facilities that actually exist, we begin with the integrated health centers, which are actually category 6. It's unfortunate that below the integrated health center, nothing really exists and nothing is budgeted below that. But just for the structure of the health system, they'll always classify from 1 to 7, of which the 7th are what they call ambulatory health posts. But as you said, there is no budget for that. So if you are targeting any intervention for health facilities, that will definitely begin as from the level of integrated health centers. Thank you. I'll be coming up with more during the discussion section.
Yeah, thanks a lot, Dr. Tambe. It's really great to hear from you. It's always so insightful when we hear from you. I did notice Mr. Delegate's hand was up. I don't know if you wanted to make a comment on Jacob's comments or.
Okay, thank you very much. Thank you very much. I want to appreciate the last speaker, Dr. Tambe, for his remarks, which are very, very pertinent. What Jacob said, I don't refute his approach, of course, as he said, resource-wise. What is important, as I just said, is the response that we can do. When you do a presentation, you do a situational analysis. What is important for us, the policy makers, is to what interventions can we do? And if we don't get the exact picture of what it is, it becomes difficult for us to think on how to respond. What do I mean? I mean, if we don't have this categorization clear, if we don't know that is these health posts that are the main body, certainly they are not the only, but if we know that they are the main body, And if we see that they are important where they are located, of course, that is when the district will propose for an integrated health center to be created at that area, and it will be created and facilities brought to a certain level that can respect certain norms. So that's just what I just meant. It's not that you will not consider, analyze, evaluate them, and put them in the situation that are acceptable for human consumption. But if we get these specificities, then it will give us a reflection on how to respond. Do we respond by shutting them? Do we respond by creating a recognized health facility that, of course, will be budgeted and improved on the services rendered to the community? So these are the specificities that I just said I should bring again, that will animate the debate right till the end of this particular program. Thank you.
Thanks a lot, Dr. Echo, and thanks a lot for those remarks. Dr. Mono.
Yeah, so I want to animate the debate by my experience. So, and it's very important that I say this because I had an experience in Cameroon at, I think, almost 3 or 4 out of the 6 levels of care. And the first time when I got an experience being in an integrated health center without water was when I was in the 4th year of medical school. And Dr. Kingsley is here, where all it in Ding Ding and Yamaswa together. He can testify for that. And there was no water in that area for the whole time when we were there. And there was built, well infrastructured, but no water. The second time, that was like, you know, there's cultural shock. But it happened to me again when I was posted in the Bamenda Regional Hospital. There was water there, but just about 5 miles away, I was actually director of the SEMA in Mancon. You cannot imagine how close it is to the Bamenda itself. There was no water in Mancon. And Kingsley can tell you, the first day I went to Mancon, there was no water at all in the hospital, not even a drop of water. There was a labor room there. There was everything you can think about infrastructure-wise. And as the director of the hospital, my first thought process is, how do I give these people water? My late dad, who used to be a contractor, had to help me get drums, which he was using for me to first of all start by collecting rainwater. Not of any good quality, but that was the first thing I did. And it just tells you that at times it's good to have these experiences at different levels, but this is just one analog things I'm proposing. I'm going to tell you a lot more, which is my experience. And there was no water there. There was no water. The next project was trying to raise the community to get a borehole, which we did before I left. And how sustainable that borehole has been and how long it's going to take government, because as Dr. Echo said, it actually reflects the community also, because there was no community. The community water project in Mancon had been unsuccessful for a long time. So because of that, also the water, there was piping into the hospital, but they lacked water because the community also lacked water. That shows you, gives you a picture of, and what I'm talking about is SEMA. Now I'm going to go to another area where I worked in Quen, which is a district hospital. Still no water. In the Northwest region, in the middle, that's areas where when I was growing up as a child, there used to be pipe-borne water. But because there is even lack of pipe-borne water in those areas, there is no water between that whole area. It covers about 3 or 4 district hospitals, going right up to the point where you reach. So you get to see that this is a situation where even providing the basics can be a problem. And when I went for specialization in CSU, there were areas in the hospital where there was no water, including the lab. I don't know those of you who have had the experience, but I'll tell you that. availability and accessibility of water becomes a problem. Even in the highest level of care in our hospitals, I know a lot of people don't want to acknowledge it, but I'm giving you my experience, anecdotal experience, which makes me to think this topic is it's a very important topic, but I'm just giving some thought-provoking discussion. I worked in Bonasama also when I left. If those who have worked in Bonasama, you will know that a borehole that was created in a sandy area blocked all the pipes. And there is water, but there are times when there is no snake, or what they call it now, there is no water. Internal water that was created, they did a borehole, but all the pipes got blocked because of the sandy area. So it shows you that this is not a problem that is just created. It's a problem that exists. Some regions are more privileged. They have more resources and more access to water than other regions. And it really becomes a big problem in other areas. So just talking about water itself, not to even talk about the state of sanitation, the state of hygiene in the hospital, waste management, and environmental cleaning becomes a problem if you don't even have water in the beginning of it all. So I'm just saying all of this is a thought-provoking situation. I don't want to say where I work, we did a study looking at hand washing. And we realized that a lot of doctors and nurses don't wash their hands too. And it became a problem where it was more of a quality project. And because people thought they were being watched, now everybody started doing it. So it's important that before getting to that level, let's provide what is necessary. But I think it can be very expensive in a country where we are not integrating the other ministries. In Cameroon, in order to provide good water, you need a lot of people involved. You need a lot of other ministries involved who have the budget to help you do that. And if the budget for health is only about 5% of our GDP budget, it becomes very difficult for us to be able to get some of these things available. But mine was just thought provocation. It was not really a question I was asking. I just wanted to give my personal experience from the time I left school to the time I worked for 2 years, and then at different levels of care. So that was just my little contribution. I don't know if the delegate has any reactions about that, but that was the situation I found. And it has always led me to say that at times I think we're very lucky. Recently, where I'm coming from in my neighborhood, it's a very wealthy neighborhood in the Northwest region, around Frontier Street, Mile 3, there has been no water there for more than 10 years. I can assure you, anyone who is coming from there, we have about 5 different community projects. None of them works in certain houses. In the region where I come, in the quarter where I came from, we've just made a borehole, 2 boreholes, and everyone thinks we are like gods that have created a borehole, something miraculous for everybody. It was a big crisis with big houses with no water running through them. And you can imagine if there's a hospital in that environment, there's going to be no water also. So it's bigger than healthcare even. In some regions, it's bigger than healthcare, really. So Brian, I'm done, but I just wanted to be provocative in my talk. And I'm provocative, realistically provocative.
Yeah, let me just make it. No, you are not provocative. You are not. Yeah, certainly we can refute the fact of the availability of these facilities within our health institutions. That is certain. The truth is, pipe-borne water is very scarce within communities, no matter the town in which you are, Yaoundé, Douala, or no matter which big town you are, pipe-borne water is really trouble. Most of our health facilities derive their water source from boreholes or automatic boreholes, and again with the epileptic electricity that we also have, at times makes it difficult for some of these boreholes, automatic boreholes, to function properly and regularly. So it's a multitude of problems. You just said it right. It's a multi-sectorial something. It's not just leaning on health. You lean on health as concerns watch, then nothing will happen. I used to say during the cholera outbreak that health has just a maximum of 40% portion to play in the prevention of or the management of it. All the other stakeholders and the other sectors have more than 50%. So leaning on health alone, that is certain that we will never reach the tunnel. We need to bring everybody on board. But we are improving with respect to boreholes. I would say with respect to boreholes, pipe-borne water, where Water just put on a new general manager, whom the first days looks promising. Let us hope and see what comes out of it.
Thank you very much, Mr. Delegate. Thank you, Dr. Eko. And truly, this problem it's a problem which I reflect about, because growing up as a child, in most of these areas, I saw water. And right now, I see pipes, but no water running. And I've never been thought about it like a problem, like a Ministry of Health problem, but I've thought about it like a systemic problem where even the Ministry of Health is unable to solve them at times.
As the delegate rightly said, it's a problem that goes beyond the Ministry of Health. If you look at our infrastructures, the Ministry of Health doesn't control water supply points. Yeah. But the moment there is a problem with a particular source, the Ministry of Health is then called up. It appears as though there is a cholera epidemic because our health facilities are not strong enough to do the job. In a publication by the CDC on what affects health, it was interesting that what we do as health professionals was given just 20%. I heard a delegate talk about 40% of the health sector in controlling cholera. Well, that is okay when it comes to controlling cholera. But if you look at all what affects health, the health sector itself is just 20%. And the social determinants of health accounted for 40%. So just the conditions in which people are born, they live, they work, they grow, and they age is double all the efforts, all the resources we put together in healthcare. And other factors come up and make up the remaining 40%. So we have a kind of a dysfunctional system where we don't have proper collaboration with the other sectors whose primary activity is not to promote health. But once their job is done, health promotion is a byproduct. So it's difficult. I don't know, at times the hammer, the focus is always on the health sector. But faced with an outbreak, what can you do? You can only investigate, okay, try to sanitize the different points. But in my first reaction, I talked about the Ministry of Water, Resources and Energy. It's very important. I talked about urban development and town planning. You see, there should be some concerted efforts. Some studies have been done in the Southwest that actually showed that there wasn't that concerted efforts between the different ministries in the management of water supply points, which is actually a problem. The Ministry of Health will not go to, we can only collaborate. We can write to the general manager of Water. We can write, we can do, that's all what we can do. So I don't know if there are meetings where the different actors actually come together and sit on the same table and all of these issues are discussed. So it is a big problem. Once we focus on the health sector for health problems that arise as a result of the fact that other sectors have not collaborated with us or they have not done their job to an extent, then I think we'll always have the same problems. In Yaoundé, we have water crisis everywhere, in Limbe, in Boya, in Douala. So I think we should actually look for a way to be able to solve this problem. Water is life, we can't do without. And talking of the hand washing thing in the hospital, you said it was more of a quality control strategy. Yes, it's a common thing in patient safety. It's called a necessary violation. How many doctors systematically wash their hands properly when they move from one patient to the other? We have a lot of reasons. The workload is too much, so you don't have time to properly wash your hands when you and your stethoscope and whatever when you move from one patient to the other. And at times the sink in the office doesn't have running water.
Yeah.
So I mean, there was a time in the imaging center in Limbe where during the Nations Cup, we didn't have water. So we had to do a makeshift solution where we fill buckets and put in those toilets where we expect our visitors to come and use. Because we're not telling that there's no water. We say, okay, we have a problem with the pressure and cook up some kind of reasons. But these are the problems most people will have. The facility where you work, you don't systematically wash your hands as you move from one patient to the other. Most doctors don't. Yeah. But it is a requirement, especially for patient safety. It's going to lead to cross-infection. So I think it's a huge debate and a subject for consideration. But at the end of the day, it's for us to contribute ideas and see how we can solve the problem. Thank you.
Excellent remarks. Thanks a lot, Dr. Tambe. Jacob, I see your hand is up. I think we'll just take one last remark from Jacob, and then we might just make a resume and then close for today. Jacob, over to you.
Yeah, thank you, Brian. I want to thank Dr. Eko and Dr. Tambe for the contributions. The issue of water is actually beyond the health facility because the health facility is just part of the community. And if there is no water in the community, then you will not expect the health facility to have water. It will be very difficult. Actually, my objective, my expectation is for us to mobilize resources beyond the ministry. You know, the government cannot solve all the problems, but what else can we do in order to mobilize people that can be able to, at least if you have one borehole, only one borehole in a community, it can serve a good number of people, and especially in a health facility. So who are other stakeholders that we can be able to mobilize them to also be part of the solution? And what I was asking initially at the beginning was, how can we use football? You know, there is money in football. Our guys, they have the dollars. And I know that what Sadio Mane is doing in Senegal, I know that other respectable players can do the same thing in Cameroon if they have the idea. So how can we mobilize these people to be able to, at least in a small way, contribute to the solution? And then I also think that, we heard at the beginning, COVID-19 actually has opened a window of opportunity in that the awareness of the importance of WASH has become very obvious. And most of the countries and the organizations are now taking steps to improve WASH. The African CDC, through the African Union, is actually working with the member state, and I was in a meeting in Yaoundé, that was in September, with the ministry, and there are already discussions in place to institutionalize IPC WASH so that it actually becomes part and parcel of the healthcare system. I am sure that with these moves in the nearest future, I believe that the situation is going to be different. But the most important question I want to ask is, we are all coming from villages. There is a health facility in your village. If you have the means, check what kind of water, whether they have water. And if you are able, can you be able to at least support that health facility or that community with a borehole in your, beginning from your village? You can do beyond your village if you are able. And so if all of us are thinking this direction, I'm sure that at least we will be contributing to the solution in a small way. And at least after some time, I'm sure that we are going to solve the problem. Thank you.
Thanks, Jacob, and I completely resonate with those comments as well. And thanks for making those remarks. I'll just take one last contribution from Cyril Bensa, and then we'll make a summary and then close. Cyril.
Thank you so much, and good evening to everyone in the house. Can you hear me?
Yes, we can.
Oh, thank you. So I'm Cyril Bensa. I'm a public health student. Let me begin by appreciating the town hall for this contribution that is driving everyone to a point of awareness as far as healthcare is concerned. And to begin with, I will actually ascertain with the first speaker who opened the chairperson of the town hall, that truly it seems like we are not learning lessons enough from the COVID-19 pandemic. I'm conducting my research on COVID, and actually it seems like we are not really learning lessons enough, especially with the easing of the lockdown measures, and that has led everything as we are returning back to normal. And hygiene has been highlighted as one of the things that were prominent during the serious COVID-19 crisis, but with the easing of COVID-19, people have taken hand hygiene once more for granted. When I hear someone talk about WASH, the first thing that comes to my mind is actually cholera, and we know the role that WASH plays to prevent cholera, but we must take that seriously. There were some questions that Mr. Jacob actually posed in his presentation. I also wish to thank him for that marvelous presentation, despite the limitations that we have raised. It was quite a good presentation, and I learned a lot from it. So he posed a question asking on how, let me take on the second question, which was, how can we improve hand wash in Cameroon? I would like to first ask, I could have loved, or I wish to engage him that he can as well do a top-bottom approach by, engaging the ministry directly, or regional delegates as well as facility managers on for them to have a discussion around that and on how to promote that. Because I believe that one of the things with Town Hall is that when we talk, we should actually get into action. So if you do that, I think that it's going to work, because he will also then highlight to them the need for the budget to be raised to the 15% that was recommended by the Abuja Declaration. And on the third question that he raised on how can we use footballers to actually go around sensitizing the population or improving watch in Cameroon. For the sake of time, I would just highlight to him that I have a suggestion that maybe we can meet after this and design a public intervention to engage those footballers around. I think that the delegate for Southwest, for Public Health of Southwest is here. He himself is here, and other persons who are experts. I think if we engage with that, it can work. So I'll just leave details to that. And to point out that when we talk about hand washing, it is shocking that though we have highlighted that there is limited access to facilities, washing water and other things, but to be sincere, the little facilities like water that is available, it will shock one to know that we don't wash our hands properly with the little water we have. Even if we were to do a random look with health personnel, if you go to funerals, celebrations, you look at the way people wash hands, even when they are being provided with water and other, detergents, it will get you surprising. So I will leave it there to say that I have a suggestion that maybe we can make behind the scenes to look at the intervention that I think I have drafted just within this short while and see if it can work. Thank you so much.
Yeah, and thanks a lot, Cyril, for your comments and your input. Definitely, that's one of the purpose and goals for this town hall. Is hopeful that we can create those kinds of connections and those kinds of collaborations in projects and ideas. And I'm really excited to hear you have an ongoing COVID-19 project and something that's related to IPC as well. I think that's extremely phenomenal. We do have a parking lot at the end of this, so during that parking lot, maybe you can you and Jacob can connect and also figure out ways in which you can work on a project together as well. I think that's going to be really phenomenal. I just want to take closing remarks from the chair before we close today, Dr. Mono.
Brian, thank you very much. I would like to start by thanking Jacob for his time and for his passion and the good work he's doing with WASH in Cameroon. And truly, your presentation today kind of touched me in an area that made me to reflect. I've never really reflected about the issue of just access to water, the first step even of the WASH process in itself in Cameroon. And I think this is going to either help me become an advocate. I have friends who have been working in trying to get boreholes into several communities in Cameroon. Maybe this is going to make me more active. There is Camp Breeze, which are the Cameroonian soldiers that are working in the UK. There is Camp Doc. There is also Mission Bore, which I know one of a friend, Akko does that. He does celebrations and does boreholes every year. So he does boreholes in different communities in Africa, a lot of boreholes because he raises a lot of money. And I think just your presentation today has been enlightening to me. And I would always love to thank the delegate for his time, his commitment, and being part of this whole town hall and this process of change. And it's always good to have someone who is on the ground who can actually enlighten us and also who can implement different decisions that we talk about. We're just talking. He's actually one of those who can actually make a lot of those discussions become a reality. And it humbles me to see that the delegate always makes time for the town hall. And I'm super always excited. And I know in the parking lot, we may have time to talk about the COVID case in Cameroon and the way forward. We all saw his communique, and as I told you, it's good to always have physicians and healthcare workers who are pro-health for their community and pro-health for their people. So I just want to thank him. I would also like to thank my friend and classmate, Professor Joshua Tambe, for always encouraging his students to join the town hall. And I think if each and every one of us does this, I keep learning every single day from every person who opens his mouth in this town hall. And I would like to say, Brian, as we always say in our private discussion, the town hall, we never knew it was going to continue for this number of weeks, months, years, but it belongs to everyone. I know they keep saying I'm chair, but I'm not really, but it belongs to everyone. It was a vision that was created where we could have a free space. We called it a town hall in the beginning because we wanted people to be able to talk freely. And one person presents, but the others are able to talk freely, exchange ideas, and we learn from each other, and we pass across knowledge to our young ones so that they'll get better than us in the future. And where we can create and foster communication, we can also actually not compete with each other, but try to acknowledge other organizations that are existing in Cameroon, other organizations that are doing good things. If you have organizations, you have people who are involved in their different processes, please don't hesitate to bring them here in the town hall. And Brian, please, can you get Dr. Eko to say the last word before we move over to the parking lot, please? I know it's time, but I'm going to stop here.
Absolutely. Dr. Eko, please take it away.
Okay, I am flattered. But again, I think we have a duty to see that things change and things be improved. If I take time, it's because we think that things have to change. We need to move forward. I sincerely want to thank the Town Hall for this initiative, all those who are the initiators. I think the first time I participated in the Town Hall, I received assistance. That was during the cholera outbreak. I received assistance of about, I think, 1 million francs from the Town Hall to motivate the personnel. I sincerely do appreciate. I am always in the Town Hall because I think I derive inspiration from the Town Hall to have some implementations of certain strategies to ameliorate, to alleviate the health situation of the region. So I am always available. I heard, I've forgotten the name, but the other colleague talked of a vision or a strategy or a project he has. I'll be interested to liaise with him even out of this to also have an insight of that. I think it will help me also to achieve the vision that I have for the region, and maybe the region might be a pilot that can be copied in other regions and whatnot the country. So I sincerely want to thank all of you, and every time I have time, I will find time to participate because it gives me inspiration. Thank you very much.
Yeah, thanks a lot, Mr. Delegate. It's really a deep honor to have you each time, and thanks a lot for joining us, and thanks a lot for your availability, your advocacy as well. And we are really, really grateful for your time. So just a brief summary of today's session. We had a quick overview of the state of WASH. WASH stands for Water, Sanitation, and Hygiene in Cameroon, and we had as our speaker, Mr. Kwan Jacob Gobte, who is an infection prevention and control and WASH nurse with the Cameroon Baptist Convention, and he's been an advocate for infection prevention and control. I initially met Jacob, as I mentioned, through a consortium that was set by the Africa CDC to enhance infection prevention and control in Cameroon. Mr. Jacob talked to us about the importance of WASH and some of the effective, some of the measures, the importance of WASH and how WASH can help improve reduction in healthcare acquired infections, the cost savings associated with it. He talked to us about the reductions in antibiotic, antimicrobial resistance, or antibiotic use in WASH. He walked us through some of the different progress that has been made across the continent. He cited the example of Zambia and Sierra Leone and Tanzania and Uganda and other countries that have made some progress. He shared with us some global statistics with the general context of WASH in the world. He shared with us some basic WASH standards. He talked to us about the basic services like just having access to water, availability, sanitation, hygiene, the importance of waste management. He talked to us about environmental cleaning. Then he dived in and shared with us some figures from a little survey that he had conducted himself in Cameroon that involved 103 facilities. And he shared with us what the status of the WASH coverage is in those facilities. He shared what the standard is and what the realities has been from those from his specific survey. So we also had a discussion about that. We talked about he talked about some of the causes of poor WASH in Cameroon, which part of it is due to limited funding. He cited the Abuja Declaration. He talked about the inappropriate distribution of resources. He talked about the lack of political will. And we also heard about how important urban development and town planning is, and how it's important to integrate the Ministry of Water, the Ministries of Urban Development and Town Planning in this conversation on improving WASH status in Cameroon. He talked about the consequences and concluded with with the fact that WASH is not being given proper attention in Cameroon, and it's unacceptably low in many facilities, and there's not enough access. So he concluded by giving us some questions to think about the access of WASH in our own communities, in our own villages. He left us to think about how we can improve WASH in Cameroon and how we can leverage sports and football and how those could be used to improve awareness on water, sanitation, and hygiene. So thank you so much, Jacob, for your presentation. It was very insightful, and we look forward to meeting all of you again at the next session of the town hall in 2 weeks' time. So thanks everyone, and we will be having the discussion after this. The back discussion after this. Thanks, everybody.
So thank you, everyone. Just stay put. We are actually going to stop sharing.